Okay, now let's continue our discussion of the cardiovascular system, and we're going to talk about the heart during this lecture. We've got a lot of material to cover. There's a lot of anatomy, a lot of physiology behind the heart, and we'll start off by talking about the anatomy in detail, and then we'll move on to the physiology. Specifically things like the electrophysiology of the heart, or how the electrical impulses are conducted through the chambers of the heart, and we'll talk about the cardiac cycle and just everything that's happening from one heartbeat to the next. So let's go ahead and dive in. Okay, what is the cardiovascular system? Well, strictly speaking, the cardiovascular system is going to be confined to just the heart and the blood vessels. Okay, I know we talk about blood during this series of lectures as if it were part of the cardiovascular system, but remember, blood is actually a specialized connective tissue, not a body system itself. So the cardiovascular system is composed of the heart and the blood vessels, and its job is to transport blood throughout the body. And what the blood does is it delivers oxygen and nutrients to the tissues, and then it removes carbon dioxide and other wastes from those tissues. Now, as it's transporting this blood, the cardiovascular system's goal is to provide adequate perfusion. What is perfusion? Well, perfusion is essentially the rate of blood that's reaching the tissues, or the delivery of blood per time per gram of tissue. Adequate perfusion is going to be perfusion that's sufficient enough to maintain the cell's health. And what do I mean by that? Well, you want enough pressure in those blood vessels to push that blood through the capillaries where they can exchange gases and nutrients and take wastes away from cells and prevent those wastes from building up and becoming toxic to the cells, and making sure that the cells have enough oxygen so that they can produce ATP, so that they can go on living. That's what sufficient delivery looks like. And in order to do that, it's going to require the heart to be pumping continually and open, healthy blood vessels. All right, let's just talk a second about blood vessels. We'll get into them in depth in the next chapter, but you need to know a little bit about them in order to understand the heart. So, arteries. What are arteries? Well, these are going to be any blood vessel that carries blood away from the heart, okay? Arteries away. Most of the time, they're going to be carrying oxygenated blood. However, there are some exceptions, and we'll talk about those. Contrast that to veins. Veins carry blood back to the heart, and most of the time they're going to be carrying deoxygenated blood. Capillaries are in between the arteries and the veins, so the blood flows from the heart through an artery, then it reaches a capillary bed, and then it comes back to the heart via a vein, okay? And what capillaries are these tiny, tiny, tiny blood vessels that are the sites of actual exchange. So those nutrients get given off to the tissues at the capillaries. Wastes get picked up from the tissues at the capillaries. Okay, so here's a look at the cardiovascular system. And on this diagram, you'll see that the arteries are labeled red and the veins are labeled blue. That's true of most diagrams. And here's the heart, and so the heart is going to pump blood, and the blood's going to leave through an artery, and it's going to get distributed through a bunch of different arteries throughout the body, okay? And that blood's going to travel down the arteries, and those arteries are going to get smaller and smaller and smaller, and we'll talk about that more in the next chapter, until they come to a capillary bed. And all a capillary bed is just this network of tiny, tiny, tiny blood vessels that are only wide enough to let one red blood cell through at a time. Okay, so these are very tiny vessels. And this is where actual exchange of gases and nutrients and wastes occur. So you can see the oxygenated blood here coming from the artery, enters the capillary bed, and then as it gives off oxygen to the body tissue, it becomes deoxygenated, and it's going to collect into eventually into a vein. And those veins are going to transport the blood from the body tissues back to the heart. Okay, so let's get into our discussion of the heart. There are two sides to the heart. There's a right side and a left side. The right side is going to receive deoxygenated blood from the body, and it's going to pump that deoxygenated blood to the lungs. The deoxygenated blood gets oxygenated in the lungs, and then it's going to return to the left side of the heart. So the left side of the heart receives that oxygenated blood from the lungs and pumps it out to the rest of the body. The heart has 4 chambers. There's 2 atria, the singular of atria is atrium, and 2 ventricles. Now the atria sit atop the ventricles. They are the superior chambers, and they receive blood, and they send that blood down to the ventricles. The ventricles are the inferior chambers that pump that blood away from the heart. So this illustration is just showing you the 2 sides of the heart. So here's the right side, here's the left side. Now here are the atria, the right atrium and the left atrium. Here are the ventricles, the right ventricle and the left ventricle. So what happens? Well, blood is going to come into the right atrium, and this is deoxygenated blood, okay, from the body. And the blood is going to get pumped from the right atrium into the right ventricle, and then the right ventricle is going to pump that blood away from the heart. It's going to go out an artery, specifically the pulmonary artery, and it's going to go to the lungs to be oxygenated. Then it's going to return to the heart through the pulmonary veins into the left atrium. The left atrium sends that blood down into the left ventricle, and the left ventricle pumps that blood away from the heart, out the aorta to the rest of the body. Next, let's talk about the great vessels. So I already kind of mentioned some of these. These are those big blood vessels that transport blood to and from the heart's chambers. So you have 2 big veins, the superior vena cava and the inferior vena cava, and these guys collect deoxygenated blood from the body and transport it into the right atrium. You have the pulmonary trunk. This is going to transport blood from the right ventricle through the pulmonary arteries to the lungs, where that blood can be oxygenated. Next, that oxygenated blood is going to go through the pulmonary veins into the left atrium. And remember, the left atrium is going to give that blood to the left ventricle, and the left ventricle pumps that blood out through the large artery, the largest artery in your body, the aorta. I want to point out a couple of things here. First, the pulmonary trunk is an artery, but you'll notice, unlike the other arteries in the body, it's going to transport deoxygenated blood away from the heart to the lungs, where it can be oxygenated, right? You'll notice here, secondly, pulmonary veins. These veins transport oxygenated blood. Okay, so these are the exceptions to the rule, where arteries usually carry oxygenated blood and veins usually carry deoxygenated blood. Well, here are just a couple of exceptions. All right, here it is drawn out for you. So here's the right atrium, and you can see these large veins coming together here to dump their blood into the right atrium. That's the superior vena cava and the inferior vena cava. Blood is going to go from the right atrium into the right ventricle and out from the right ventricle through the pulmonary trunk. Remember, this is an artery because it's transporting oxygen away, artery away. And then that blood goes to the lungs, it gets oxygenated, it comes back through these guys, the pulmonary veins. And it's kind of hard to see, but these pulmonary veins extend all the way over and kind of plug into the posterior portion of the left atrium. Okay, so oxygenated blood comes into the left atrium. The left atrium pumps it into the left ventricle, and then that left ventricle pumps that blood out through the aorta, the largest artery in the body. Okay, how does the blood flow just one direction through the heart? So you can see here, it's going to come in from the atrium and go into the ventricle. Well, when that ventricle contracts, what makes the blood go through the artery instead of back into the atrium where it came from? Well, the answer to that is heart valves. Heart valves ensure one-way flow of blood through the heart. There's two sets of heart valves. There's the atrioventricular, or AV valves, and then there's the semilunar valves. The AV valves are going to sit between the atrium and the ventricle on each side of the heart. You have the right AV valve. This is also called the tricuspid valve. It's named because there are three cusps in this valve. And then there is the left AV valve, or the bicuspid, because there are two cusps. You'll also see the left AV valve called the mitral valve. And the reason for that is because it resembles a mitre, which is a type of headwear worn by certain religious leaders of some Christian denominations. Next, you have the semilunar valves, and this is going to be the pulmonary valve and the aortic valve. And the pulmonary valve is going to be located between the right ventricle and the pulmonary trunk, and the aortic valve is going to be located between the left ventricle and the aorta. Okay, so let's take a look at the valves. Here's the right AV valve, or the tricuspid. Here's the left AV valve, or the bicuspid. Here is the pulmonary valve. And then here, it's kind of hard to see. It's kind of tucked behind the pulmonary trunk here is the aorta, and here's the aortic valve. So deoxygenated blood is going to come into the right atrium, and then it's going to pass through the right AV valve into the right ventricle. Now, you'll notice the pulmonary valve is closed at this point. What's going to happen is the right ventricle is going to contract, and that's going to force blood upwards. And that blood is going to push open this valve, the pulmonary valve, and it's going to slam shut this valve, the right AV valve. Same thing happens on the left side of the body, okay? When the left ventricle contracts, the blood rushes upwards and it pushes open that aortic valve, and it slams shut that left AV valve, and that's how the blood is kept flowing in one direction. Okay, so there are two circuits that we are talking about in the cardiovascular system. There's the pulmonary circuit, or the pulmonary circulation, and the systemic circuit, or the systemic circulation. The pulmonary circuit is short, okay? It's only going to involve those structures that are transporting blood from the heart to the lungs, and then from the lungs back to the heart. Okay, so it's going to take deoxygenated blood from the right side of the heart, send that to the lungs. It goes through the capillary beds of the lungs. It picks up oxygen. Now it's oxygenated blood, and that's going to return to the left side of the heart into the left atrium. That's the pulmonary circulation. That's all it is. Compare that to the systemic circulation. This is the longer circuit. Okay, this is where oxygenated blood from the left ventricle gets pumped out through the arteries, the various arteries in the body, to the different body tissues. In those body tissues, they enter capillaries, and that's, remember, where the exchange of nutrients and gases and wastes occurs. And then that deoxygenated blood is going to return from those capillaries into veins, into the large veins of the body, the vena cava, and return that deoxygenated blood to the right atrium. And then that deoxygenated blood is going to enter the pulmonary circuit. All right, let's talk a little bit about congestive heart failure, cardiomegaly, and edema. You'll see all of these are kind of interrelated in this congestive heart failure picture. What is congestive heart failure? Well, It's either the impaired ability of the ventricles to fill with blood or the impaired ability of the ventricles to pump the blood. If the ventricles are having problem filling with blood, that's called diastolic heart failure. If the ventricles are having a problem pumping the blood out, that's called systolic heart failure. And the reason for that, we'll talk about a little bit later, is because the contraction phase of the heart is called systole, and the relaxation phase of the heart is called diastole. The reason it's called congestive heart failure is because when the pump stops working like it should, for either one of these reasons, blood is going to back up in the system, and we call that vascular congestion. Okay, to compensate for this, what the heart does is it just starts pumping harder and faster, and it's going to develop cardiomegaly, which is the condition of an enlarged heart. So those muscle cells, the cardiomyocytes, are going to enlarge. That's hypertrophy. And when in doing so, there's going to be less overlap of the myofilaments. They lose their optimum amount of overlap. So the heart cannot forcefully contract as much as it could before. Because we've got blood backing up behind this failed pump, we're going to get body fluid disturbances, okay, such as edema. Okay, this is showing diastolic heart failure versus systolic heart failure. So in diastolic heart failure, there's going to be a problem with the ventricles being able to fill up enough blood. And you can see here this left ventricle is very thick, and so is the right ventricle even. And so that makes these chambers really thick and stiff. And so they can't expand when blood is pumped into them. And so you get less blood pumped out from the heart. And that means more blood is backing up in the left atrium here, or the right atrium here, whichever side is failing. Now, with systolic heart failure, you're going to get kind of the opposite. You're going to get these big floppy chambers, okay? And the muscle cells in there are stretched thin and they're weak, and they cannot contract forcefully enough to move this blood forward. And so you get a backup of blood behind the ventricles. And that backup of blood, that vascular congestion, can lead to edema or swelling. Okay, and there's a couple of just broad types of edema I want you to be familiar with. There's systemic edema, and this is going to happen where there's more blood remaining in the systemic circulation, and so fluid is going to kind of leak out of the systemic circulation. It's going to get pushed out of those blood vessels into the surrounding tissues, the interstitial space. Okay, so that's one way. And then there's pulmonary edema. This happens when there's more blood remaining in the pulmonary circuit. And so blood backs up into the capillary beds of the lungs, and fluid is squeezed out from the increased pressure into the lungs. And that can cause breathing difficulties and problems with gas exchange. Systemic edema, you're generally going to see things like an enlarged liver, a big soggy liver, swelling in the legs and the feet, sometimes swelling in the belly. That's called ascites. And generally, this is going to occur if the right ventricle fails. If the right ventricle fails, blood is going to back up into the right atrium, and then it's going to back up into the superior vena cava and the inferior vena cava, and that's going to back up into the veins throughout the body. And you can see how the pressure inside of those veins can build up to where fluid leaks out and causes edema. Pulmonary edema typically occurs when the left ventricle fails. So if the left ventricle fails, you're going to have blood back up into the left atrium. And what's behind the left atrium? Pulmonary veins. So you're going to have blood back up into the pulmonary veins, which are going to back up into those capillary beds of the lungs. And in those capillary beds, that increased pressure from all that extra blood in the system is going to cause fluid to leak out. And that fluid is going to fill the air spaces of the lungs, and it's going to make breathing really difficult. Here is an example of both cardiomegaly. So this is an enlarged heart. This heart should not be this big. As well as pulmonary edema. So you can see kind of these fluffy white areas throughout the lungs. These should not be there. They should be nice and dark, like up here. You can also see this angle down here where the lung ends. The angles are kind of blunted, and that means there's fluid collecting in the pleural space. And this is happening because of left-sided heart failure. Okay, where is the heart located? It is within the thoracic cavity. The thoracic cavity is supported by the thoracic cage, and the thoracic cage consists of the ribs, the sternum, and the thoracic vertebrae. The heart is going to sit posterior to the sternum, a little bit left to the body's midline. It's going to sit between the lungs in a region called the mediastinum. It's a little bit rotated. The right side of the heart is more anterior than the left. So think of the heart as like it's pointed a little bit towards the left. The base is the posterior-superior surface of the heart, while the apex is the antero-inferior end, or the conical end of the heart. All right, here's the heart in the thoracic cage. You can see it sits posterior to the sternum, a little bit left to the midline of the body, and then it's rotated leftwards. You can see this is the right ventricle here. This is the majority of the right ventricle that you can see from this vantage point. You can only see a little bit of the left ventricle from this angle, and that's because the heart points leftwards or is rotated leftwards. Now let's say we cut the body at this level. What would we see? Well, this is what we would see. Now this is the inferior view, so the way to look at this is to think of yourself as if you have a patient who's laying down on a table and you're standing near their feet and you're looking up at them, up at their head. Okay, that's what you're seeing here. Here's the right side of the body. Here's the left side of the body. Here's the heart. This is anterior. This is posterior. And you can see the right ventricle here lies more anterior than the left ventricle. The heart is enclosed in a sac, and that sac is called the pericardium. It's a fibrous-serous covering, meaning it has a fibrous portion and a serous portion. The fibrous pericardium is the outermost covering, and it's composed of dense connective tissue. It's going to attach to the diaphragm, the base of the aorta, the pulmonary trunk, and there it's going to help anchor the heart and also prevent the heart from overfilling. Next, you have the serous pericardium, and you have two layers of that, the parietal layer, or the outermost layer, and the visceral layer, or the innermost layer. Now, the parietal layer is going to consist of simple squamous epithelium and areolar connective tissue, and that's all attached to the fibrous pericardium. The parietal layer of the serous pericardium then kind of folds back onto itself and becomes the visceral layer of the serous pericardium. Again, this is going to be composed of simple squamous epithelium and areolar connective tissue, but it's going to be attached directly to the heart. For this reason, it is also called the epicardium. And I said that parietal layer of the serous pericardium folds back onto itself and creates the visceral layer. And so those two serous layers are continuous with one another, and they're going to be separated by a potential space, the pericardial cavity. And what's in that cavity is a little bit of serous fluid. And that serous fluid acts as a lubricant. So as the heart beats, the pericardium doesn't rub against the heart and create friction. Now, the fibrous pericardium and the parietal layer of the serous pericardium together form what's called the pericardial sac. Okay, so let's take a look at that. So here you have the heart. You can see it's kind of surrounded by this this sac. And so what is that composed of? Let's zoom in real close, and it's going from outwards to inwards. You have the fibrous pericardium here, and that's going to attach directly to the parietal layer of the serous pericardium. And that parietal layer of serous pericardium folds back onto itself and attaches directly to the heart. And now it's called the visceral layer of the serous pericardium. There's a space between the parietal and visceral layers. This is the pericardial cavity, and it contains serous fluid, and that helps to reduce friction as the heart beats. All right, let's talk a little bit about pericarditis. What is that? It is the inflammation of the pericardium. This can be caused by a variety of things. Most often it's infectious, so caused by viruses, bacteria, or fungi, but it can be autoimmune or even due to certain medications. What happens with inflammation is you get leaky vessels, you get increased capillary permeability, and just what that means is that fluid can leak out of the capillaries more easy than it usually can. And so the problem with this is that you get a fluid buildup in that pericardial cavity right here. So you get fluid buildup here, and it can expand so much that it presses down on the heart chambers and prevents those heart chambers from being able to fill up. That is called cardiac tamponade, where the heart becomes unable to pump because there's so much fluid surrounding it, pushing against those chambers. The heart can't fill up with blood. A friction rub is a crackling sound you hear with a stethoscope as the heart beats and the pericardial layers rub together. So a friction rub is a sign or an indicator of pericarditis. Okay, this illustration is showing what cardiac tamponade kind of looks like. So imagine the pericardium is see-through. And now you can see that there's fluid accumulating in that pericardial cavity. And it's going to continue to accumulate, and when it does, it pushes against the chambers of the heart, and the heart cannot fill up like it should. And so you lose the ability to pump enough blood to keep your tissues alive. All right, now let's talk about the superficial features of the heart. So what can you see on the anterior view, or when you're looking at the anterior side of the heart? Well, you can see the right atrium and the right ventricle. You can see the right atrium's auricle, which is this wrinkled extension of the atrium. You can also see portions of the left ventricle and the left auricle as well. Also visible are the pulmonary trunk, and then it splits into right and left pulmonary arteries. You can see that. You can see the ascending aorta, the aortic arch, and the descending aorta. And you can see this thing called the ligamentum arteriosum. This is between the pulmonary trunk and the aorta, and it's a remnant of the fetal ductus arteriosus. The ductus arteriosus functions to shunt blood in the fetal circulation. Okay, so here is the anterior view of the superficial features of the heart. So you can see, starting here with the right atrium, and then the right auricle here. This is the right ventricle. You can see part of the left ventricle here, and the left auricle here. Here's the pulmonary trunk, and it's going to divide into left pulmonary artery and right pulmonary artery. Here's the aorta. It ascends from the left ventricle and kind of arches backwards, and so that's why this is called the aortic arch, and then it becomes the descending aorta, and the descending aorta continues through the thoracic cavity down into the abdominal cavity and feeds all of the organs there. Here is the ligamentum arteriosum. In the fetus, this works to shunt blood away from the pulmonary circuit. If you think about it, the fetus is getting their oxygen from mom, not from their lungs. They cannot breathe in utero, so their lungs are not used for oxygenation. So there's no need for blood to enter the pulmonary circuit, and so the ligamentum arteriosum helps that blood bypass the pulmonary circuit and go straight out to the body, straight into the aorta, where it can feed the rest of the body. And then just to point out, this area down here is the apex of the heart. Okay, what can you see on the posterior view of the heart? Well, remember the anterior view, you're going to see the right atrium and the right ventricle very prominently. In the posterior view, you're going to see the left atrium and the left ventricle very prominently. You're also going to be able to see the pulmonary veins attached to the left atrium, the superior and inferior vena cava, as well as the pulmonary arteries. You're going to be able to see the posterior interventricular sulcus. I'll show you that in a second. And as well as part of the coronary sulcus that houses the coronary sinus. Okay, this is the posterior view of the heart. So back here, you're going to be able to see the left atrium really well. You can see the pulmonary veins feeding into the left atrium. You can see the left ventricle. Most of the posterior surface of the heart is going to be left ventricle. You can still see some right ventricle here and a little bit of the right atrium. You can see the vena cava coming in and feeding the right atrium. You can see the pulmonary trunk and the pulmonary arteries coming towards you. And you can also see the aorta, the ascending aorta, the aortic arch, and then the descending aorta. You can see the coronary sinus here, and this is just a collection of coronary veins, and they come together to form the coronary sinus. And the coronary sinus is located in the coronary sulcus. What is a sulcus? The plural of sulcus is sulci, and what sulci are is they are grooves on the heart surface. The heart has a few sulci. There's the coronary sulcus. This guy is going to separate the atria from the ventricles. And then you have the interventricular sulci, and these guys separate the left ventricle from the right ventricle. You have one on the front of the heart and one on the back of the heart. There's the one on the front of the heart is the anterior interventricular sulcus, while the one on the back is the inferior or posterior interventricular sulcus. And what these grooves do is they contain the coronary vessels that supply blood to and from the heart wall. All right, here is the external anatomy again. You can see the right atrium. Here's the auricle of the right atrium. You can see the right ventricle here. And separating those two is the coronary sulcus. And that coronary sulcus kind of wraps all the way around the posterior side of the heart and comes back around this left side. Okay, so remember, it's separating both ventricles from both atria. On the anterior view, you can see the anterior interventricular artery, and this guy is located within the anterior interventricular sulcus. Okay, here's the posterior view of the heart, and just to get you oriented, this big sac right here that we're looking right at is the left atrium. Below it is going to be the left ventricle. You can see part of the right ventricle from the posterior view as well. And you can also see part of the right atrium. You can see the pulmonary veins coming into the left atrium. So here's one vein, here's another vein, here's the third vein, and here is the fourth vein. You can see the coronary sulcus, and you can see it wrapping around down here beneath the right ventricle, right atrium, excuse me. It wraps this way beneath the left atrium and continues around to the anterior side of the heart. You can see the inferior interventricular artery right here, and this is in the inferior or posterior interventricular sulcus. All right, now let's talk about the heart wall. The heart wall is going to vary in its thickness throughout the heart. So the ventricles are going to have thicker walls than the atria do, and the left ventricle is going to be much thicker than the right ventricle is. And the reason for that has to do with which circuit each one of these ventricles supplies. So remember, the right ventricle is going to supply the pulmonary circuit, and the pulmonary circuit is very short. The right ventricle only needs to generate enough force to get the blood from the heart to the lungs, and the lungs are right there next to the heart, so it doesn't have to generate a lot of force. The left ventricle, on the other hand, supplies the systemic circuit. You're trying to provide blood to the entirety of the body, and so you're going to need to generate a lot of force, create a lot of pressure to get that blood out into the extremities, into the different organs. So your left ventricle is going to have a much thicker wall. Okay, the heart wall has 3 layers. From outermost to innermost, it's going to be the epicardium, the myocardium, and the endocardium. The epicardium we've already talked about. Remember, this is the serous layer of the visceral pericardium. It's the outermost heart layer, and it's composed of simple squamous epithelium and areolar connective tissue. Next, you have the myocardium. This is the middle layer. It's the thickest layer, and this is where that cardiac muscle tissue is that contracts and pumps blood. Finally, the innermost layer is the endocardium. This is going to cover the internal surface of the heart and the external surface of the heart valves. It's composed of simple squamous epithelium and areolar connective tissue as well, and it's continuous with the inner lining of blood vessels, which is called the endothelium. Here we're looking at a section through the heart, so we're looking at the heart wall. This is the outermost layer, the epicardium. Then here's the middle layer, the myocardium, and the innermost layer, the endocardium. Okay, what separates the heart chambers? Well, you've got an interatrial septum that's going to separate the left atrium from the right atrium, and you have an interventricular septum that's going to separate the left ventricle from the right ventricle. Okay, now let's talk about each chamber in a little bit more detail than we have so far. So start with the right atrium. The right atrium is going to have some muscles. These are called the pectinate muscles. These are ridges on the anterior wall and within the auricle. You'll also find the fossa ovalis in the right atrium. This is an oval depression on that interatrial septum. And what the fossa ovalis used to be is it used to be a hole called the foramen ovale. And what the foramen ovale did in the fetus was it allowed blood to go from the right atrium to the left atrium, helping to bypass the lungs. Because remember, baby gets oxygenated blood from mom, not by using their lungs. The right atrium is also going to have several entrances. It's going to have the entrances from the coronary sinus, and this guy carries the blood from the heart wall. Okay, so the heart wall is a muscle. It needs oxygen just like every muscle in your body. And so you have coronary arteries that supply that heart wall and coronary veins that bring the deoxygenated blood away from the heart wall. And those coronary veins converge into the coronary sinus. You'll also find the entrances for the superior vena cava and the inferior vena cava in the right atrium. And blood is going to move from the right atrium through the right AV valve into the right ventricle. The right ventricle has some muscular structures. It has the trabeculae carni. These are irregular muscular ridges inside of the ventricle wall itself. And it also has these muscles called papillary muscles. These guys are cone-shaped projections that extend from the internal ventricle wall, and they anchor the chordae tendineae. The chordae tendineae are strands of collagen that go from the papillary muscles to the AV valve, the right AV valve, and they attach there. And their job is to anchor that right AV valve and keep it from flowing backwards when the ventricle contracts. Blood is going to exit the right ventricle superiorly through the pulmonary semilunar valve into the pulmonary trunk. Okay, then blood is going to go to the lungs, it's going to get oxygenated, and it's going to return to the left atrium via the pulmonary veins. The left atrium also has pectinate muscles in its auricle, It has entrances as well from the 4 pulmonary veins, and blood is going to exit the left atrium to the left ventricle through that left AV valve. The left ventricle also has trabeculae carni, and it has 2 papillary muscles that again are going to anchor those chordae tendineae, those heartstrings that hold those valves closed when the ventricle contracts. Blood is going to exit superiorly to the aorta through the aortic valve. Right, so let's look at all those features on the chambers here. Here's the right atrium. You can see several openings. This is the opening to the inferior vena cava. This is the opening to the superior vena cava. This is the opening to the coronary sinus. This is the fossa ovalis. This used to be open and allow blood to shunt from the right atrium to the left atrium when you were a fetus. And here you can see the pectinate muscle of the right atrium. Moving down to the right ventricle, you can see the trabeculae carni here, these ridges of muscular tissue inside of the ventricle. And then you can see the papillary muscles. Those are these conical muscles here, and you can see that they're attached to these thin, long strands of collagen. And these strands of collagen attach to the valve, the leaflets of the AV valve. And so when this ventricle contracts, it pushes blood this way, and it's going to slam this valve shut. But what prevents that valve from just opening up this way and allowing blood to go through? These chordae tendineae do. This is what anchors those leaflets and prevents them from backflowing. Okay, a little bit more about those valves. Remember, valves ensure one-way blood flow. That's their purpose. Remember, there are 2 types of heart valves, the AV valves, or the atrioventricular valves, and the semilunar valves. And remember, the semilunar valves are going to be the aortic valve and the pulmonary valve. All the valves are made of endothelium-lined fibrous connective tissue, cusps. Okay, that's what the leaflets are called. They're called cusps. The AV valves are going to prevent backflow to the atria. Remember, the right AV valve is between the right atrium and the right ventricle, and it's also called the tricuspid valve. The left AV, or mitral valve, is between the left atrium and the left ventricle, and it's also called the bicuspid valve. The AV valves are going to close when those ventricles contract. Those ventricles force blood superiorly, and that slams the AV valves shut. That papillary muscle and those tendinous cords are going to hold the AV valves in place so that they don't flow backwards and allow blood to move past the valve. The semilunar valves are going to prevent backflow of blood to the ventricles. They open when the ventricles contract. They increase that pressure inside of the ventricle until the force is so great that blood is transported from the ventricle into those arteries. They're going to close when the ventricles relax. And what happens is that pressure, that blood pressure in the arteries becomes greater than the blood pressure in the ventricle, and the blood kind of slips backwards. And as it slips backwards, it catches the cusps of those valves and snaps them shut. Each of the 2 semilunar valves has 3 cusps. Remember, there's the pulmonary semilunar valve located between the right ventricle and the pulmonary trunk, and there's the aortic semilunar valve located between the left ventricle and the aorta. Okay, so here we're looking at the function of the AV valves and the semilunar valves. So here's the blood flow from the atrium into the ventricle. Here's the AV valve, and it's open. And then when that ventricle contracts, blood is going to be forced superiorly. So it's going to be forced back up towards this AV valve. And what happens is when it does that, it kind of snaps these valves together, and that prevents blood from flowing from the ventricle back into the atrium. Now, when that ventricle contracts, it's going to force that blood superiorly, and it's going to actually open the semilunar valves. Okay, so ventricle contraction is going to close the AV valves and open the semilunar valves. When the ventricle relaxes, the pressure inside of the ventricle becomes lower then the pressure inside of the arterial system, and the blood kind of slips back down towards the heart. And you'll see that these cusps are designed just so that they catch that blood, and that force of that blood sliding backwards snaps them shut. All right, now let's talk about hypertrophic cardiomyopathy. This is where the heart walls grow inwards. It's another cause of cardiomegaly. And the problem with the inward growth of the heart walls is that it's going to narrow the openings for blood to pass through. And so that's going to decrease cardiac output, or in other words, decrease the amount of blood that the heart is able to pump out. The cause of hypertrophic cardiomyopathy is genetic. It's confirmed by an ultrasound. And this condition is going to be exacerbated by strenuous exercise, okay, as well as dehydration. And it can result in sudden death. Here on the left, you have normal heart with a normal heart wall. Here on the right, you have hypertrophic cardiomyopathy. So you can see here it's the interventricular septum that has thickened primarily, and it's obstructing the outflow tract, okay? So it's obstructing this path where blood needs to leave the ventricle, and that is a massive problem. This can become completely blocked, and that's when you get sudden cardiac arrest. Okay, let's talk a little bit about heart sounds and heart murmurs. What makes the heart sound, the lubbed up, that sound of the beating? Well, it's going to be the closing of the heart valves. S1 is the first heart sound. It's also the lub in lubbed up. It is closing of the AV valves, okay? And then you get S2, the dup in the lubbed up. That's due to closing of the semilunar valves. There are some minor heart sounds that you can hear occasionally. These are called gallops, the S3 and the S4. And these guys are clinically useful because they usually indicate an underlying problem. Now, each valve is going to be best heard at a specific anatomic location on the chest. All right, so let's look at a video that goes over the first and second heart sounds.
Let's now take a closer look at what causes the S1 and S2 heart sounds. The S1 heart sound occurs when the tricuspid and mitral valves close simultaneously. This is followed by ventricular contraction, otherwise known as systole, and this forces blood through the pulmonary and aortic valves. And the S2 heart sound occurs when the pulmonary and aortic valves close. A period of heart muscle relaxation then occurs, and this is known as diastole, after which the cardiac cycle starts all over again. Let's now add in the heart sounds with this animation. The four heart valves and their respective heart sounds can be auscultated in the following anatomical areas.
What is a heart murmur? Well, a heart murmur is an abnormal heart sound, and it's going to be the result of turbulence of blood passing through the heart. Some heart murmurs are benign, but some are medically important, and those that are medically important, there's two general types. A heart murmur due to valvular insufficiency, or a heart murmur due to valvular stenosis. Okay, valvular insufficiency, this is going to occur when the cardiac valves leak because those cusps aren't closing tightly enough. And so what happens is you get backflow of the blood back into the chamber that it just came from. And you can get heart enlargement from this. So, for example, if you have insufficiency of the left AV valve, you'll get blood backflowing into the left atrium, and that can stretch the left atrium and enlarge it. On the other hand, you can get valvular stenosis. This is the opposite problem. This is where the valve cusps are scarred, and so they can't open all the way. And so this is going to resist blood flowing through the valve. it's going to reduce the output that that heart chamber is able to produce, right? So less blood is going to be able to be moved out of that heart chamber. And a big cause here of valvular stenosis is rheumatic heart disease. The heart has a fibrous skeleton made up of dense, irregular connective tissue. It's going to be located at the boundary of the atria and the ventricles, so where they meet, and it forms fibrous rings, and this allows a place to anchor the valves. It's also going to provide a framework for attachment of the cardiac muscle, as well as act as an electrical insulator. Okay, and that electrical insulation is going to basically block the signal, the impulse to contract, that's being sent from the atria down to the ventricles. It's going to block most of that signal and only allow it to go through one specific place, the AV node. And the reason for that is because if you didn't do this, the ventricles could be triggered to contract at the same time as the atria, and that would be catastrophic. Now, the cardiac muscle tissue itself is arranged kind of in a spiral arrangement. The muscle cells are going to be attached to the fibrous skeleton, and they're arranged in these bundles, these spiral bundles. I'll show you a picture in just a minute. But the overall effect is that it's going to allow for atrial contraction, the walls to move inward during atrial contraction, and it's going to cause ventricular contraction to resemble sort of the ringing of a mop. So contraction in the ventricles is going to begin at the apex and kind of go superior, and it kind of wrings the blood out of the heart. And here is that fibrous skeleton. And here are the cardiac muscle bundles we just talked about. So up here, the atria are going to contract and the atrial walls are going to move inward. Down here, the ventricles are going to start contracting at the apex and kind of work upwards, and that brings the blood from the bottom of the ventricles up superiorly. All right, as we've mentioned, the heart is an organ, and so it needs its own blood supply. It needs to be supplied with oxygen and nutrients, and it needs CO2 and wastes taken away from it. And the circuit that does that is the coronary circulation. You're going to have the coronary arteries. These guys transport oxygenated blood to the heart wall. And you're going to have the coronary veins. These guys transport deoxygenated blood away from the heart wall back toward the right atrium. Okay, so what happens is you get these two main arteries, okay, the right main coronary artery and the left main coronary artery. They're branching off of the ascending aorta. In fact, they are the first branches off the aorta. The heart likes to prioritize itself. And these guys sit in the coronary sulcus. And what they're going to do is they're going to branch into several different arteries. So the right coronary artery is going to branch into the right marginal artery, and this supplies the right heart border. And the posterior interventricular artery, and this supplies the posterior left and right ventricle. You might also hear the posterior interventricular artery referred to as the PDA, or the posterior descending artery. The left coronary artery branches into the circumflex artery. This supplies the left atrium and ventricle. And the anterior interventricular artery, or the left anterior descending artery. And this guy supplies the anterior surface of the ventricles and most of the interventricular septum. You may have heard of a particular form of heart attack called the widowmaker. All that is a heart attack due to obstruction of the left anterior descending artery. This is a huge artery, and if you block its blood flow, you're going to have catastrophic, sometimes instantly fatal results. Okay, here's the right coronary artery coming down, and you can see it gives way to several branches, but the ones to be familiar with are the right marginal artery, which supplies the right heart border, and the posterior descending artery, or the posterior interventricular artery. Here's the left coronary artery coming down, supplying the left side of the heart. So we get the circumflex artery here, and then this big guy right here is the anterior interventricular artery. And blockage of this guy is what is called a widowmaker. Arterial anastomoses are connections between vessels that allow blood to arrive to a destination by more than one route. Coronary arteries are end arteries. That means that the blockage of a coronary artery is going to lead to insufficient flow to the heart wall. An end artery is an artery that once it reaches its destination, it doesn't make connections with any nearby arteries, okay? So the coronary artery, the coronary circulation does have some anastomoses, but they're far too small in order to be a proper route, alternate route for blood to take. So if you block a coronary artery, you're blocking essentially all the blood flow to the region of the heart that that coronary artery supplies. Coronary blood flow is intermittent due to the heart contractions. Okay, so the contraction of the heart is going to momentarily prevent blood from flowing through those coronary arteries. The vessels, the coronary arteries, are going to be patent or open when the heart relaxes. So the heart muscle receives blood during its relaxation phase or diastole. Okay, and then you've got the coronary veins, and these guys drain the heart muscle. You have the great cardiac vein, the middle cardiac vein, and the small cardiac vein, and they're all going to converge into the coronary sinus, and it's the coronary sinus that drains into the right atrium. Here's the great cardiac vein, the small cardiac vein, and the middle cardiac vein back here, and they all come together and form the coronary sinus. Okay, let's talk a little bit about coronary heart disease, angina pectoris, and myocardial infarction. So coronary heart disease, this is the buildup of plaque specifically in the coronary arteries. The term for the disease that causes those plaques to build in blood vessels is atherosclerosis. And the problem with plaques is that they reduce blood flow to the heart muscle. And what a plaque is it's essentially a collection of lipids and cholesterol and some white blood cells and things like that that get inserted into the innermost lining of the arterial wall. Plaques can grow in size and reduce the amount of blood that can flow past them. And so they can grow to such a size that they completely occlude or block off the artery. A coronary spasm occurs when there's a sudden narrowing of a coronary vessel. Now, both coronary heart disease and coronary spasm can lead to angina or even myocardial infarction. Angina, or angina pectoris, is heart pain during strenuous activity. Usually people feel this on the left side of their chest, radiating down their left arm, or up the left side of their jaw. Myocardial infarction, on the other hand, is also known as a heart attack. And this is the sudden and complete occlusion of a coronary artery. Sometimes what can happen is a plaque can break off and occlude the artery, or like we said, a plaque can grow so large that it occludes the artery. Sometimes you can get a thrombus in there that occludes the artery. So there's a lot of different potential mechanisms that cause myocardial infarction, but the overall picture is that a coronary artery gets suddenly blocked. And when that happens, blood cannot flow to the heart wall, and so the myocardium becomes deprived of oxygen, and this is going to damage those cells and possibly lead to cell death. Symptoms here are going to be that chest pain, left-sided chest pain especially, radiating usually down the left arm, up the left side of the jaw. And when you get pain that's occurring at a location different from where the source of the pain is, we call that referred pain. Referred pain happens because the wiring of the nervous system is very complex, and there's a bunch of different nerves entering the spinal cord at about the same area, and they travel up to your brain, and sometimes the brain misinterprets the signals that it receives and thinks, that a signal from one location is actually coming from another location. Okay, now let's talk a little bit about the microscopic structure of cardiac muscle. So the myocardium is composed of cardiac muscle tissue. Cardiac muscle is going to contain these short branched cells. These cells have one or two nuclei. They're supported by areolar connective tissue called the endomysium. These cardiac muscle cells have a cell membrane, of course, and that cell membrane is called the sarcolemma. That sarcolemma invaginates inwards towards the cell, and those invaginations are called T-tubules. And those T-tubules extend into the sarcoplasmic reticulum. The sarcoplasmic reticulum is a storage network of calcium, okay, that surrounds myofibrils. Myofibrils are made up of many myofilaments. You may recall the myofilaments are the thin filaments, or actin, and the thick filaments, or myosin. And these myofilaments are arranged in units called sarcomeres. And it's their organization into these units called sarcomeres that gives rise to the striated appearance of these muscle cells under a microscope. We'll talk about this a little bit later in this lecture, but the optimal length, that is the maximum overlap of the thin and thick filaments, is actually seen when the heart is stretched, okay? So as blood fills the chamber, that stretches the heart, and that brings those filaments to their optimal length. And so this allows the filaments to contract with the greatest force as blood fills up the chamber. The individual muscle cells are going to be connected to one another with these things called intercalated discs. Intercalated discs are primarily composed of two things: desmosomes, which hold the cells together, and gap junctions, which are basically these channels that allow ions to flow from one cell to the next cell to the next cell, so that they all work together as a functional unit, and this is called a functional syncytium. Okay, so here's a cross-section of a cardiac muscle cells, and you can see this is one cell. You can kind of see how it branches here, and it's got two nuclei in it. This is the sarcolemma, or the cell membrane, and you can see it invaginates and forms these channels called T-tubules, which dive into the cell towards the sarcoplasmic reticulum. You can see multiple myofibrils. There's one, here's another one, and each myofibril is going to be composed of many myofilaments. Remember the thin filaments and the thick filaments, and those guys are arranged in these units called sarcomeres. So this is a sarcomere, this is a sarcomere, this is a sarcomere, okay? You'll also notice numerous mitochondria throughout the cell, and that's because muscles require a lot of oxygen in order to work. This and this are intercalated discs, so if we zoomed in, we could see the desmosomes here holding one cardiac muscle cell to another cardiac muscle cell, so that's kind of what binds them together. And then you have these things down here called gap junctions, and these are channels that allow ions to flow from one cell to the next, allowing the whole heart to kind of contract as a unit. Here's what cardiac muscle looks like under the microscope. So here are those intercalated discs that connect one adjoining cell to another. Here are nuclei. So this cell looks like it has two nuclei in it. This cell appears to have two nuclei as well. So they can have one or two nuclei. And then you can see here the striations throughout. And again, that's because of those repeating units called sarcomeres. Okay, cardiac muscle, the metabolism of cardiac muscle. It has a high demand for energy, like we mentioned. Okay, so it's going to need a lot of oxygen, a lot of ATP. So it's got an extensive blood supply to make sure that nutrients and oxygen get to it. It has numerous mitochondria. The cells are packed full of mitochondria in order to make that ATP. Cardiac muscle also has some storage molecules. So there's myoglobin. This is a storage molecule for oxygen. Then there's creatine kinase. This is actually an enzyme that helps store ATP. Cardiac muscle can use several different types of fuel molecules, so things like fatty acids as well as glucose. It can even use lactic acid, amino acids, and ketone bodies. And it's going to rely mostly on aerobic metabolism. So remember, that's when you go into oxidative phosphorylation. It involves the mitochondria, and it involves oxygen. Anaerobic metabolism does not involve oxygen, and that generally is just glycolysis. Glycolysis makes much less ATP than cellular respiration does, than oxidative phosphorylation does. These guys rely on aerobic metabolism because that's how they're going to get the most ATP possible. The problem with this is that it makes these cells susceptible to failure when they are ischemic, that is, when oxygen supply is low. So any interference with blood flow to the heart muscle can cause cell death.